Hello to all the viewers of ATN. We're here today to introduce to all the viewers Dr. Surendra Ugale. Dr. Ugale is a surgeon who specializes in various different types of bariatric surgery. Please tell us a little bit about your educational background and your medical training.
All my education was done in Mumbai, including my medical training. And then about 25 years ago, I moved to Hyderabad and I got into laparoscopic surgery at an early stage in India. And then it progressed to advanced laparoscopic surgeries, then to bariatric surgery, and then even more complex and advanced, the surgery for diabetes.
Just tell us briefly about laparoscopic surgery. What does that entail?
So laparoscopic surgery involves making small incisions on the abdomen as opposed to making a big incision and doing an open surgery where you would do the surgery with your gloved hands. In laparoscopy, you would insert instruments and with the help of a camera, you would see all the insides on a big screen with magnification, and then you would do the surgery with the help of those instruments without actually physically handling the organs yourself. Bariatric surgeries have been in place for a long time, for at least 45-50 years. Bariatric surgeries were created for weight loss, but then they found that it has a fringe benefit of control of blood glucose, so they were used for diabetes also. But then the even more diabetes specific surgery, which started in Brazil in 2003, that came about, and that is specifically for diabetes, and you can give weight loss as a fringe benefit when you need that.
And it's my understanding that you actually went to Brazil and got
That's right.
Specialized clinical training from the pioneer in this field.
Well, this was in 2007. I was with my American friend who was a very famous laparoscopic surgeon, Dr. Barry Solke from Mount Sinai in New York. And he mentioned that he was heading for Brazil because he had this friend who does this surgery for diabetes. And when I heard that, I said, my God, the problem of diabetes is so huge in India that I'd love to learn this surgery. So he asked for me, we both went along, and then we were trained by the pioneer, whose name is Dr. Aureo de Paula in Goiânia in Brazil. And we both underwent the training, we came back, and then Dr. Barry Solke did get IRB approval in New York to start the operation, but unfortunately he didn't get enough funding because it was expensive to the tune of 65,000 US dollars, I was told, and so he was not able to start that. Fortunately, I was able to start it in the beginning of 2008, and then we got it established in India.
Tell us briefly about your facilities in Hyderabad.
Right now, we are doing all these surgeries at a dedicated center, which is a small but specialized and focused center where we do bariatric surgeries and more of the diabetic surgeries. So at surgery, I need 2 other surgeons with me so that we can coordinate well and expedite the surgery. The nurses are trained in laparoscopic and bariatric surgery. The team on the anesthesia front is also familiar and well versed with these types of surgeries, because sometimes we have diabetics who may be morbidly obese, some may be having heart issues, may be having problems with the kidney. So it helps for us to have a team that understands all these different aspects, and so we can do it safely for our patients. We are different from the usual other surgeries because we would, for example, in the post-operative, need monitoring of blood glucose every 3 hourly and control of blood glucose. So they are tuned to this, and that is a big help for all the post-operative care. Well, the actual surgical operation takes about 4 to 6 hours on an average. Then we keep the patient in the post-surgical, the ICU for observation for a day, it may be 2 days, depending on requirement. Then they are shifted to their room and they are allowed to walk, they are allowed to climb stairs, and the blood sugars are checked. They are given intravenous fluids and they are started on liquids from say 36 hours after surgery. And then we work them up gradually with the fluids, and for the first week they will be on fluids. And usually their stay in the hospital is at least 4 to 5 days with the surgery. If needed, we might have some patients in longer.
And then, how long after a patient is discharged does it take for the patient to start integrating back into basic activities of daily living and progress into sort of normal life activities?
We usually find that between 8 to 12 days, most people can get back to their normal work. They are not allowed to lift any heavy objects at that time, but in a month's time after surgery, they are allowed to do everything.
In terms of the surgical procedure for diabetes, am I correct? Primarily for a person to manage their diabetes or control their diabetes, there are two approaches: what I'll call the conservative approach or the surgical approach. Conservative management would involve medication, and most people, if that doesn't work, will require insulin. At what point in time would you recommend somebody to contemplate or think about getting surgical treatment to manage their diabetes?
So the first thing that we need to point out is the fact that surgery is available and can be used for diabetes, because traditionally diabetes has been a disease which stays with you lifelong, where you have to take your medication as tablets. When it gets worse, you go on to insulin and more insulin, and there's no other way out. Well, fortunately, as I said, when the bariatric surgeries were found to have a beneficial effect on control of blood glucose, surgery began to be used for diabetes control. Now, when a person has diabetes which is in the initial stages, when it's mild, they have an option. And the option is that if they really make some efforts, they could do a reasonable control of their diet, use exercise nearly every day or at least 4 or 5 times a week, try and reduce mental stress and your approach to stress in life, because as human beings we all have stress. But if you can learn to handle the stress, that's a very important factor, because many of the diabetics, they get pushed into diabetes with an episode of severe stress. So if they are able to do these things, and if they need some medication, they take some medication which is regular, they get their checkups done regularly. If they are overweight, have some obesity, if they lose weight, it's going to help them a great deal. So these are things which anyone can do, and the first approach should be a preventive approach, because all over the world the incidence of diabetes and obesity is increasing, and unless the governments do something to do something on the preventive scale, on the preventive side, on a large scale, it's going to be a hopeless situation. Because even if, let's say, we have 100 specialized teams doing these diabetic surgeries, how many people can you operate? And so people have an option in the beginning. That's what I want them to know, that you have an option, exercise it. Then you don't need to go in for surgery. Don't look for an easy way out. Now, when you find that in spite of your diet and exercise and reduction of stress and your medication, the diabetes is still marching on, then this diabetes can be stopped by surgery. So that is when they should look for the alternative.
What what is the eligibility, or what are the requirements for someone to be shortlisted or be eligible or be entitled to the surgical approach to managing your diabetes?
Well, we would look at
Factors, criteria that you look at.
yes. We firstly need to ensure that the diabetes is not a type 1 diabetes. So we need to make sure they're type 2, which is the majority in the world. 95% of the people in the world are type 2 diabetes.
Okay.
Then we take an age group from 20 to 70 usually. Sometimes even beyond 70 if they are very active in life and contributing to society, or they are getting into complications, then we would like to be more aggressive a little beyond 70 if they are fit for anesthesia. And when they find that, as you mentioned earlier, that in spite of everything the diabetes is worsening, that's when we would look at them. Now at times we take in people whose duration of diabetes is maybe at an early stage, maybe 1 year, maybe 2, 3 years. These are individuals who have a very strong family history of diabetes, and they may have history that one of their family members had kidney failure, had dialysis and transplant, or somebody died, somebody's had heart attacks, and the coronaries were affected, and they died from that. So when there is aggressive form of diabetes that we see, then we would take people on earlier, even at an early stage, because these are the individuals who are really going to need help to prevent the complications.
And so once you've determined that for a person or for a patient, surgery will be beneficial, what does the surgical procedure actually involve? In as simple terms as possible, so that our viewers have an understanding of what the surgery actually entails. Can you tell us what is the science or the methodology behind the surgical procedure?
So before that, probably I should clarify how we choose the patients for surgery. We would take a detailed medical history. Then we ask them to do some blood tests, because we see what is the pancreatic reserve. And we need some functioning pancreatic cells which can produce insulin to be working. And we can estimate this by doing some blood tests. If the response is favorable, then we know the surgery is going to be successful.
Okay.
And once we take them up, then it is a laparoscopic, minimally invasive surgical procedure. We need to do this under general anesthesia, so they need fitness for general anesthesia. So we screen all their systems, the cardiac system, the lungs, the kidneys, make sure everything is all right. And then under general anesthesia, we take 6 small incisions. So they are a tiny 0.5 centimeter or 1 centimeter incisions, which are used, and with the instruments inside, then we operate in 2 areas. One is on the stomach and the other is on the small intestine. On the stomach, we need to remove a portion of the stomach which would depend on the weight and the BMI of the person. And the other thing which happens when you do any removal of a part of the stomach is your initial nutrients which you take, the portion of the meal, they would be emptied from the stomach rapidly.
Okay.
And this is useful for us because the second part of the operation is where we take a segment of the ileum, which is a distal part of the small intestine, and we transplant it, bring it higher up in the intestinal tract.
Okay.
So now the food which has emptied rapidly from the stomach, the undigested food gets into this ileal segment. It stimulates the special L cells which are here in the intestine, and they secrete large amounts of a hormone called GLP-1.
Okay.
And this hormone is good for the pancreas. And when it acts on the pancreas, it helps the pancreas to secrete more insulin. It prevents, in some time, it stops the death of the cells of the pancreas, and then later it's supposed to improve the cells of the pancreas. So traditionally, this is how the procedure is done. At the end, We usually might have a fine tube, which is a drainage tube placed, which is removed maybe after 3 or 4 or 5 days. And as I said earlier, the patient is on intravenous fluids but is mobile right from the day of surgery or the next day itself. Majority of the people, since we've been selective in the selection process, we pick the people who are likely to respond because of the pancreatic reserve being sufficient. So majority of the people, to the extent of 90%, would go off all their medication. And the others would improve and go from a severe form of diabetes with poor control, would come down to a very easy, stable form of control with some medication. So all our patients would respond.
Yes.
So we don't have failures as such, and that's how good it can be. And it probably takes, for some people, they respond very rapidly, and by the time they are leaving the hospital, they might not need any medication, or they might need a few medicines initially, and in a few weeks or a couple of months, the blood glucose starts to settle down and we reduce the medication, and in some time they don't need any medication at all. And then they're able to eat, and the body is able to handle foods which have carbohydrates, any sweets or desserts, and the body is able to take care of that and maintain normal glucose. And along with the blood glucose, since it's a metabolic issue, so there are a lot of metabolic abnormalities in the body. As I mentioned, you have blood pressure, you may have high cholesterol and triglycerides. All these problems simultaneously improve and settle down, and most times all the medication stops.
So 90% of patients are likely going to essentially be off medications.
That's right.
So we can say that in that percentage, in that 90% of the patient population, their diabetes is cured.
In a clinical sense, yes. If one looks at it in a very scientific or in a technical way, we can't really say a cure, because the cure has to be at a microscopic level where every cell has to be reversed.
Okay.
But it is as good as far as a person is concerned, a patient is concerned, it's a cure, because now they can eat everything. They
don't need medication
they
or
don't
insulin?
need any medication or insulin, and the blood glucose is normal.
Okay.
And the pills, even for high blood pressure, and the other pills also would go off.
So practically cured, but in scientific terms, in remission.
Yes.
Now, you mentioned earlier you started conducting this procedure in 2008. So you have been doing this for 8 years.
That's right.
What negatives, if any, have come to your attention for patients who have undergone the surgical procedure?
Well, most times there is an inconvenience of intake that happens in the beginning, and some of our patients would complain that they are not able to take in food or sometimes fluids, and there might be an episode of vomiting. So they may have this inconvenience, which usually settles down. If we find that is bothering them a lot, then we ask them to get an endoscopic examination done at the end of 1 month. Some patients may have an episode of loose stools, diarrhea, just like you've had some infected food, and with some medication that is controlled easily. And we suggest that most people go on to probiotics, have yogurt, and with that helps to maintain a healthy mix of good bacteria in the bowel. Because in the procedure, as I mentioned, we transplant a segment of the small bowel from the distal part, get it nearer the upper end, and so there's a shift of the bacteria that normally lodges in those segments. So when you convert all the bacteria into healthier bacteria, this helps them. Besides this, we generally don't find much of a problem. Some people may experience an episode or two of weakness, which may be transient. And that's why we encourage everyone to be positive, because as we realize, the mind factors are important too. So people who are more sensitive or more uh, afraid, more pessimistic, they're more likely to experience some symptoms. So we encourage people to be positive, get back to normalcy, forget that they had surgery, a month after surgery at least, and live a normal life. So when this happens, we find that most people don't have any issues at all. And any small symptoms like these, whether it is some acidity or episode of a loose stool or something, I control easily. Besides this, we've not really found any major issues or complications.
One of, in terms of reviewing the benefits of the different types of bariatric surgery that is being conducted, you see that some procedures actually result in malabsorption.
Yes.
With respect to the specific diabetic surgery that you perform, is there any concern with respect to malabsorption?
A study had been done in Brazil where they studied patients to see whether there was malabsorption in ileal interposition as compared with the bypass surgeries. And they found that 95% of the bypass surgery patients had malabsorption, while in ileal interposition there was no malabsorption. So that is really good for us and for our patients, and for us to know that we can give them a procedure that is effective, and yet we do not give them one more disease of malabsorption.
And so you're not replacing one problem with another. So ileal
That's right.
interposition results in significant improvement, or like you said, from a practical perspective, the diabetes being cured without causing any significant malabsorption.
That's right. That is true. And one also needs to note that there is a huge segment of the population of people with diabetes who are not morbidly obese. So they do not qualify for the bariatric surgery. So what do you do for this whole segment, which has no other hope but medication and more medication? Well, we can do ileal interposition for all these patients. And if they're in the morbidly obese group, then they have a choice of going in for the bariatric surgery or for ileal interposition. And what has been seen as far as the results go, that if the diabetes is milder, then a simple bariatric surgery will help them, and that's fine. Whether you do the sleeve gastrectomy, which is slimming of the stomach, or you do any of the bypass surgeries. But has been seen if the diabetes severity is more, it's moderate or it's severe, then those procedures are not able to completely solve the problem of diabetes in the patients. So again over there, ileal interposition seems to work the best, which is why we suggest to surgeons that more people should get trained and have this in the armamentarium, and they can use the appropriate procedure for a patient.
Dr. Ugale, thank you very much for sharing the wealth of knowledge and information you have. If a patient is interested in discussing the ileal interposition surgery to help them manage or control their diabetes, can you please, for their benefit, provide us with the location of your hospital, your contact phone number, and contact email?
Well, we are based in Hyderabad, and people could reach us through email. My personal email is Surendra Ugale, SURENUGALE @gmail.com. They could reach me through WhatsApp on +91 for India, 957-3200-951. Or they could contact and speak to my nutritionist, whose name is Swapna, and she's on 970-368-4164. People could also go to our website, which is diabetessurgeryindia.com. So these are the different ways that people can reach us, and we can get back to them and guide them as to what is the best thing that they can do for themselves.
Thank you, Dr. Ugale. Thank you very much.